Hi, this is Jim Thigpen. I'm providing you a shortened, highlighted version of my larger presentation entitled Bugs in Babies, which is Management of Infections in the Neonate. So just to hit a few of the highlights from the talk, Coag-negative Staph is definitely the most commonly seen infection in the neonatal population, especially in late onset sepsis. Vancomycin still remains the first drug of choice. What you have to ask yourself is what dose you're going to use. Historically, we started out with 10 milligrams per kilogram per dose. We've progressed that to 15, now to 20 milligrams per kilogram per dose, based on what we've learned about vancomycin over the years and how these pathogens are becoming a little more resistant. And then you have to look at what interval you're going to use, and that is largely based on the gestational age of the baby, the estimated renal function that the baby has, or a combination of the two. So older children may require, or older infants may require Q12, Q8, or even as much as Q6. I wouldn't recommend starting with Q6. I would wait until you have evidence, i.e. trough levels, to tell you that you need to reduce your interval down to a Q6. But that is not uncommon. The younger the baby is, or the poorer the renal function is, the length of the interval needs to become Q24, Q36, or maybe even Q48. If you have a lot of suspicions with the renal function, it's best to give a single dose of 20 milligrams per kilogram and then get a random level about 24 hours later to determine what interval you want to use from there on out. And it depends also on what levels you're trying to achieve. More sensitive pathogens with a lower minimum inhibitory concentration, or MIC, which is less than 1, you can get away with a little lower trough level between 10 to 15. Higher MICs, greater than 1, would require a trough level in the 15 to 20 range for the most effective therapy. There may be, and realize, and I've kind of alluded to this already, there may be a 2 to 3-fold difference in vancomycin clearance within a neonatal age range. You may have a baby in one bed that requires Q36 vancomycin, and you may have one which is probably older, probably born more close to term, but might be the same gestational age that requires Q12 or Q8 dosing. So there could be a big difference from one baby to the next, so that needs to be considered. Other comorbidities can affect vancomycin elimination, and these are usually related to renal impairment. Other medications like ibuprofen or indomethacin can certainly cause an effect on the vancomycin clearance, as does dopamine, and ECMO certainly has an effect, which is different but significant, that needs to be addressed separately. So what kind of Staph aureus are we talking about too? Methicillin resistant or methicillin sensitive? And that really means a lot as far as what your initial therapy tends to be, because methicillin resistant really requires vancomycin all the time. Methicillin sensitive Staph aureus, you have a more broad choice of antibiotics which actually are more effective than vancomycin. But in today's environment where we have much more methicillin resistance, you have to start with vancomycin and then pare your therapy down to something that will just cover MSSA if that's in fact what you grow. Somewhat newer medications that may or may not be familiar to you include linezolid or Zyvox. It is now generic. It has been around long enough for that. It's an oxazolidinedione antibiotic which inhibits protein synthesis by binding 23 and 50S ribosomes, and so they inhibit protein synthesis by that manner. They're bactericidal against strep and bacteriostatic against enterococcus and staph. They have a very wide distribution into the body, the lungs, the CNS, so they are a good option or a good alternative to vancomycin. Personally, if I had a patient with a CNS Staph aureus infection, I would give vancomycin along with Zyvox or linezolid to try to make sure you get as much drug in that CSF as possible, because vancomycin does not penetrate the CSF very well. The main thing to look for with linezolid is your blood counts, especially neutropenia is something that you will see in probably 10% of the patients that receive the medication, so be aware of that and be looking for it. The dosing there for you, 10 per kilo, and then you change the interval based on the baby's age. Daptomycin is another antibiotic that's directed against staph and strep. Somewhat newer medication, works by a different mechanism, but has a very broad spectrum against other gram-positives like Enterococcus faecalis too, and VRE, and would be a good option if Vanc or linezolid fail. The main thing to remember about about daptomycin, it is really not for pneumonia. It's inactivated by the lung surfactant, and so therefore it might not work in pneumonia, or it might not work in endocarditis, specifically left-sided endocarditis, but most physicians would not prescribe it to someone with endocarditis in general. Has a very favorable side effect profile, We do have some information in neonates, but not very much. We really need more information on this medication before we're comfortable using it. What about some gram-negatives? If you have to treat somebody with gram-negatives, your first initial therapy, of course, should be something to cover gram-positives like vancomycin. And then you've got quite a few options to cover gram-negatives like aminoglycosides, very broad spectrum, very stable, not a lot of resistance with aminoglycosides, but you're certainly concerned about nephrotoxicity and ototoxicity, especially with the combined drugs that both can cause that problem. If you think about an alternative to that would be a carbapenem like meropenem, a very broad spectrum beta-lactam antibiotic. You almost have to remember what it does not cover. The biggest concern with carbapenem is just that it's so broad spectrum that if you don't need it, you shouldn't use it, because when you expose a child or expose bacteria to real broad spectrum antibiotics, you're more likely to see a resistant pathogen the next time. The same thing applies with piptazo. Very comparable as far as its spectrum of activity as to carbapenem. There are some holes compared to carbapenem, but they're very rare, but it would be a good option. But again, if you don't need it, you should need to pare your therapy down to not predispose that child to more antibiotic than it requires. So again, start with vancomycin plus a good gram-negative drug. A single gram-negative drug might work, but if you have MRSA as a potential pathogen, you have to cover for it, and so you need 2 drugs. Pay attention to what your own NICU has grown in the past, look at your antibiogram, and direct your therapy accordingly, and then always pare your coverage down once you know what you're treating. So what medications really should be avoided? I've kind of alluded to this already. Cephalosporins, aminoglycosides, cephalosporins specifically because of the concerns about future resistant pathogens, and that also includes funguses that might show up once you've given a more broad spectrum antibiotic. Aminoglycosides, vancomycin for their nephrotoxicity, and carbapenems, again, for the same reason you might want to avoid cephalosporins. Or your concerns, you may not be able to avoid those antibiotics, but you need to be looking for things that you may encounter in the future. Thank you very much. For more information or for the larger presentation, please click on the link below. Thanks.